I think that the positive benefit of prenatal diagnosis is that it can help us to identify cases that benefit from immediate, life-giving, life-restoring care when seconds matter.
Welcome to Caring for Both, the Curbside Consult series by the American Association of Pro-Life Obstetricians and Gynecologists, APLOG. On this podcast, we bring on experts to provide insights to support you as a medical professional in your life-affirming practice. I'm your host for today, Dr. Susan Bain. I'm a board-certified obstetrician and gynecologist, and I'm the vice chair on the board for APLOG. So we're going to talk about prenatal testing and diagnosis today, and it's a hot button issue for pro-life advocates. We've heard the stories of parents who are immediately pressured to terminate upon receiving a potentially life-limiting diagnosis or even just a life-altering prenatal diagnosis. Their medical team often implies or outright states that this is the only viable path forward. If they choose to continue their pregnancy, they can be faced with opposition or receive lower quality care. So as medical professionals, perhaps we've witnessed our patients experience something like this, which really just adds tragedy and trauma on top of an already difficult situation. So as a result, it's understandable that many pro-life patients choose to forgo prenatal testing altogether. They get scared of it. But what if there's another way to think about prenatal diagnosis from a life-affirming perspective? So here to offer an alternative perspective is our guest today, Dr. Brandon Brown. Let me tell you a little bit about him. So Dr. Brown is a pediatric radiologist working at Riley Hospital for Children at Indiana University Health, as the chief of fetal and perinatal imaging, and formerly as Director of Physician Vitality and Values for Indiana University Health. His clinical work is at the intersection of several areas of medicine as one of the founders of the Fetal Center at Riley Children's Health. And he's a member of many departments, including radiology, pediatrics, obstetrics and gynecology, surgery, philosophy, and medical humanities. Dr. Brown's research focuses on imaging techniques in high-risk pregnancy, MRI of placental blood flow and its relationship to fetal abnormalities, and perinatal ethics. In 2005, he served as a graduate research fellow at the Indiana University Center for Bioethics, and he is currently a member of the section on bioethics for the American Academy of Pediatrics. Finally, Dr. Brown, we are excited to say, is one of our speakers at our 2025 MBEC conference. We're actually recording this conversation in advance of MBEC, so by the time it's published, Dr. Brown will have given his lecture on the same topic. So for those of you who aren't aware, the recordings of our MBEC lectures are actually going to be available online for enduring continuing medical education credit. So you can actually register today to view those talks once they become available, including Dr. Brown's. You simply have to go to conference.aplog.org. So I strongly encourage our listeners to register to watch Dr. Brown's full lecture that he's going to give you a little teaser on today as we talk. So Dr. Brown, thank you so much for being here today.
Thank you for having me. It's a real treat to be here.
Great. Well, tell us a little bit. I know we had the nice intro that's kind of that formal bio, but tell us a little bit about yourself. How'd you end up, I went to med school too. I'm not sure if you wrote about this in your entrance exam or entrance essay, or it just evolved. We'd love to hear how this unique work you're doing came about.
Well, it certainly wasn't my master plan. So if you believe in the idea of vocation or calling, then I guess we could say it's something that I didn't even know I was being called to. And I went into medicine, being interested in imaging and being interested in, diagnosis and everything. So I had some great mentors who steered me towards radiology, but I actually trained as an interventional radiologist. And so I thought my career would be in pediatric interventional radiology. But, as it turned out, when I was ready to start my job, there were no jobs in that particular field that worked for me. So I decided to start out in doing pediatric and especially neonatal diagnostic imaging. And it just happened that right around the time I was starting out as a faculty physician at Indiana University, the OBGYN department here had a major change in leadership and major shift in their attending physician ranks. And so it was kind of a new moment for them. It was a new moment for me. And I had some great interactions with colleagues there. And we sort of decided we want to build something that can focus on high-risk pregnancies, specifically related to, maybe prenatal interventions. And we took it from there. We worked for a number of years to build a fetal center. And, there's great models out there in Houston and Boston and Cincinnati and other places, Philadelphia. But we wanted to do something here in the Midwest. And we got together a great group of people, very collaborative group. So I get to work regularly on a team with surgeons, neonatologists, maternal fetal medicine specialists, and all the associated subspecialties. So I love the multidisciplinary character of the work, and I love our ability to kind of wrap ourselves around the families who come to us and need help, not just, surgery, and not just medications, but also the kind of support that comes from feeling like there are physicians and caregivers willing to shoulder the burden. And it can be, a pretty serious burden to have a high-risk pregnancy. So it's work that I love, and it's work that I feel is very important.
Tell us a little bit more about the typical patients you see at this center when you talk about journeying with them.
Yes. So almost all of our patients at the Fetal Center are referred to us. So first they would see their OBGYN, of course, and if a concern is raised, they might get referred to a maternal fetal medicine specialist. And then I have, I'm really glad to say, really strong relationships with the maternal fetal medicine specialists here in Indiana. And I frequently just, in the middle of the day, get a phone call from one of them saying, hey, here's this thing happening. I've got this patient showing up in my office. I'm not exactly sure what we're seeing on ultrasound. Can I send him down to you? So we get referred from all over the state. Indiana is, I think, a little bit in the minority in that we only have one academic medical center in the entire state. So we're sort of the destination for places as far north as Chicago, or almost Chicago, and all the way down southern Indiana by Kentucky and Cincinnati and Ohio. So we get patients referred to us. They have a concern, and our job, as I see it, is to help them to understand as much as possible about what this is going to mean. That's what I mean. We can tell them the technical terms. We can use fancy words like ventriculomegaly or agenesis of the corpus callosum or whatever you like. But at the end of the day, they all want to know, what does this mean? What's this going to look like? And so, I think that part of it is developing, a diagnosis and then a treatment plan. But more than that, in this world, a lot of what we're doing is helping them to look ahead and see what is going to change in their life. So, many of these very complex fetal anomalies aren't just a one and done fix. You come in for your treatment and then, that's it. But they may need to go to a major city, even if they live hours from a major city. They may need to be in the, NICU for weeks or even months. And how's that going to change your life? What about my job 2-3 hours away? What about my older children who have to go to school every day? How am I going to manage all of this? So I think a lot of our work is the prognostication and the family counseling that helps them to understand, A, this is going to be an effort that is difficult, but we can work together on it. And B, you're not alone in this. You're not abandoned to kind of shoulder this heavy burden all by yourselves.
Yeah, that sounds like you definitely are on the path with them and trying. I love the concept of it's not just a diagnosis, but what does it mean? So, when you think about medicine and how to do this well and how it's not always done well, what's the difference in those two approaches, do you think?
That's a great question. And I hesitate to talk about others not doing it well because I'm sure there's been many times when I myself have fallen short. But I think at our worst in healthcare, we can be very afraid of uncertainty, and we don't want to get things wrong because it can harm patients, but also because, we're concerned about our own uh, protection. And so we don't want to be
Right.
accused of doing the wrong thing. And that can cause, I think, it can be a temptation to distance ourselves from a problem and to create
Hmm.
a lot of space. So, when I was first coming into medical training in the late 90s, there was a lot of talk about how we need to avoid paternalism. The idea that the doctor is always right, we give the
Right.
orders, and the patients accept our commands. And it was good to move away from a very authoritarian model that I think probably did exist in places. But the dark side of that is now we maybe stand back and we say, oh, here's the alternatives. You can choose A, B, C, or D. I couldn't possibly tell you what to do. You have to
Hmm.
make that decision for yourself. Good luck.
Yeah.
And patients just feel like, oh my gosh, I don't, what does this even mean? How do I choose? What's it
Yeah.
going to look like? So there can be a temptation to kind of keep our patients at arm's length and say,
Hmm.
you are the decider. And I think we need to respect the autonomy of our patients for sure, but they need our help. They need our assistance, not necessarily just information assistance. Here's what you should do. But like I said, the idea that they feel alone, they feel isolated, they feel afraid, and that requires a kind of compassion. So I think at our worst, we can try and hide from the uncertainty, but gosh, life is uncertainty, and medicine certainly involves a
Yeah.
lot of uncertainty.
Yeah, from 21 to 22, I spent a year at Duke Divinity School in their theology, medicine,
Mm.
and culture program. And I remember one of the most powerful things I learned that year was that balance between paternalism and autonomy, and that I was walking into the room as Susan Bain, all of me, and I was bringing medical expertise. And my patient was bringing expertise in her own body and her own lived experiences, but together we could partner and journey on this healing process, whatever that may look like. As you know, if you think about the purpose of medicine being for health, healing, and wholeness.
Yeah.
And it really gave me permission not to have to fix my patient, but actually to journey with her. I was much more than a provider. I wasn't a technician. I was actually a professional coming in with some expertise, but she knew herself better than I knew herself in that regard, for my maternal patients. So when you think about those patients that are scared of, I think there's become some lack of trust in those individuals who really value a life of want a doctor that practices a life affirming approach, meaning they do not use death as a therapeutic modality, and are afraid that when they go visit a doctor, if they've gotten a potentially life limiting condition, that they won't get that full informed consent. So the what's this mean for our family, but also the perinatal palliative care that can be offered to these families. What message would you want to share to those of us who are OBGYNs or family practice docs who are seeing women and their preborn children to give those families confidence in us?
Yeah, that's a great question. I think I think that as you know, as we all know, the way we talk about medicine and health and disease can really shape the decisions that our patients make. So
Mhm.
if I bring you, say you've got this high risk pregnancy, ultrasound identified something in the brain, we don't know exactly what. And if I bring you in and I say, I'm very sorry to report that there's an abnormality in the brain of your fetus, and there's structures that are missing, and we don't know what it's going to mean, but outcomes can range from disability to death, and there's no intervention known at this time. I mean, I can really make it sound dark, but I can take the same condition and say, ultrasound failed to reveal the cavum septum pellucidum. However, we know that it's not 100% sensitive and specific, and we also know there are cases where this may not have any effect on outcomes. So why don't we do a little further investigation? We have other imaging modalities we could do, because sometimes, ultrasound may fail to detect something that other, imaging such as MRI could detect. So we can look further, and then also to approach our so-called evidence with some humility, which is to say, we know some things, and we often know more than our patients know, but there is a lot we don't know. And especially when it comes to predicting long-term outcomes in a child's life, their growth and development, sometimes I think we speak with just a little too much confidence about what will happen, how bad it will be. And that's a disservice, because I think that we can manipulate outcomes by doing that.
Yeah, that's a great point. I think humility is a very good virtue for all of us to have. So as you think about if a woman's saying, I'm not sure if I want any of this testing in my pregnancy, what are some of the benefits to having the testing?
Right. I'm glad you brought that up. Because I think that there has become a little bit of a caricature of prenatal testing, and people that I've spoken with who are maybe a little hesitant or skeptical, it immediately evokes images in their mind of China's one-child policy, or gender selective abortions, or using this information to get rid of pregnancies. And I think that while that, has happened and does happen, I don't think it has to happen. And prenatal diagnosis, in my particular field, prenatal imaging, is a tool. And we can use our medical tools well or poorly. We can use them for good, or we can use them to harm. And so we're increasingly coming into an awareness that there are a lot more therapies available for patients that were formerly thought to be, to have lethal diagnoses. And one of my favorite anecdotes is when I was starting out, there was a neonatologist that I really respect and learned a lot from, kind of a mentor for me, even though we're in different fields. And he was at the end of his career. He's since retired. But he said, when I was starting out as a neonatologist, a diagnosis of trisomy 21 meant we would not do any intervention. It was basically an indication for no treatment. We would provide supportive care, but no one would ever do surgery on a patient with trisomy 21 because it was thought to be futility, medical futility. And now here we are, 50 years later, and that would be malpractice, right? To not provide therapy. So we have to ask ourselves, who is the patient today who we think, man, futility, there's nothing to be done, who 50 years from now, people will look back and say, what were they thinking, So I think that the positive benefit of prenatal diagnosis is that it can help us to identify cases that benefit from immediate, life-giving, life-restoring care when seconds matter. So, I just had a patient the other day with a large congenital epulus, gingival cell tumor filling the mouth, grown out of the gums. And we identified this on prenatal imaging, both ultrasound and MRI. This is not a malignant condition. This is not a life-threatening condition, but it was so large, it was completely obstructing the oropharynx and the hypopharynx. So if we didn't know about this, and this patient is born, they're not going to be able to breathe right away. And you can't just whip up a quick little surgery right there on the spot. It's going to take
Right.
time. And as we know, time is brain, and anoxia is devastating. And there's so many cases of cerebral palsy that are the unfortunate result of us not being prepared.
Mhm.
So I think that's a great example of something that is, I say easy, and of course that's a relative term. It's a simple repair, but it was the difference between life and death, and we had to know in advance. So
Right.
I think that that's one way in which prenatal diagnosis can make a big difference.
Yeah, I often, when patients, when I would talk to them and they were hesitant about it, I would share to them, this is information we're gathering. It doesn't mean we have to do A, B, or C, but there is value. And you gave a perfect example of by knowing before the birth, you were probably able to save that baby's life, you
Yeah.
know, because you can't quickly intubate or do, as you said, the surgery if there's a blockage like that. Wow, that's a neat story. So, one final question. When you think about the next generation, I assume you have medical students or residents that you interact with.
I do.
Um, APLOG really cares about the next generation. We care about them knowing how to practice life affirming medicine, where both the maternal and fetal patient matter, and that we don't want them to feel like they're the only ones that think that. Because I think sometimes it can feel lonely, and just maybe this is a little philosophical kind of just thinking about. But what do you see with this new generation? What do you hope that they can learn as they go through training in this post-Dobbs era where there's a lot of craziness and chaos going on?
Yes, there sure is. And it can be intimidating, especially um, if you are in a powerless situation. And our students and our trainees have very little power. And
Yes.
so the fear quotient is very high. If you're the
Hmm.
chair of a department, it's a little bit different. So
Right.
I often, I am really grateful that a number of medical students here at Indiana University over the years have come over once a month. We do a reading and discussion group, and we get to talk about these scenarios. What should they do when they feel cornered, or they feel powerless, they feel alone? And one thing I've often found interesting is that we tend to overestimate how alone we are. I
Mm.
don't know if you've ever read the short story, The Man Who Was Thursday. It was written by G.K.
No.
Chesterton. It's a quick
Okay.
read, and the plot, spoiler alert, is about a secret agent who's in enemy territory and is, maneuvering around like a spy because everyone around him is, if they knew who he was, that'd be the end. But as the story progresses, he keeps meeting people and discovering they also are secret agents. They also are working for the good, even though they're in the midst of this very toxic environment. And I suspect that each of us is unaware of someone or some persons in our sphere who are trying to do a thing with care and with, wisdom and prudence. And we underestimate where those partnerships could be.
Mm.
So I think that I have been really encouraged that by reaching out to others, by talking about how we need to have a better sense of solidarity in medicine to care for the good in one another. We need to have a better sense that each of us is part of a story that's much bigger than just our own individual journey. Um, I've discovered a lot of people sort of in that fearful position who are looking around, and connecting those dots, connecting those people has been it's been a very fulfilling endeavor. And I would say that each of us, whether you're a member of this society or others, could serve in that role to bring people together who thought they were alone. And I guess I try to wake up every day and say, who can I connect? Who needs to
Hmm.
be brought, to a new
Right.
vision? And that's, I think, an important role each of us can play.
What a great reminder. Tell us the name of that book again.
The Man Who Was Thursday by
I love that
G.K.
concept.
Chesterton. Yeah, it's a
Okay.
fun
The
story.
Man Who Is Thursday. Fantastic. Well, thank you so much for being with us, Dr. Brown. And thank you to our listeners for joining us today. If you like this episode, please be sure to give us a like and subscribe on our YouTube channel. Or if you're listening on a podcast app, give us a 5-star review. So we will see you on our next episode, and happy to be connecting at MBEC in less than a month.
Thank you so much.